A condition associated with one or more non-bizarre delusions of thinking, such as expressing beliefs that occur in real life, such as being poisoned, being stalked, being loved or deceived, or having an illness provided no other symptoms of schizophrenia are exhibited. Delusions may seem believable at face value, and patients may appear normal as long as an outsider doesn't touch upon their delusional themes. Mood episodes are relatively brief compared with the total duration of the delusional periods. These delusions are not due to a medical condition or substance abuse. Themes of delusions may fall into the following types. Erotomanic type. Patient believes that a person usually of a higher social standing is in love with the individual. Grandiose type. Patient believes that he has some great but unrecognized talent or insight, a special identity, knowledge, power, self-worth, or special relationship with someone famous or with God. Jealous type. Patient believes his partner has been unfaithful. Persecutory type. Patient believes he is being cheated, spied on, drugged, followed, or somehow mistreated. Somatic type. Patient believes he is experiencing physical sensations or bodily dysfunctions, such as foul odors or insects crawling on or under the skin, or is suffering from a general medical condition or defect. Mixed type. Characteristics of more than one of the above types, but no one theme dominates. Or unspecified type. Patient's delusions do not fall in described categories.
The problem in the definition of delusional disorder that you can't define it really. Some of the people with delusional disorder are more intelligent, having more wisdom than the psychiatrists they are treating them. Why? In delusional disorder, the problems are so cornered in a small issue in life. For example, some people have infidelity about their wives. Other than that, they are very productive in their work, etc., and everything. But when it comes to that area, he's totally abnormal. If you are dealing with that patient as a friend or a colleague and you are not touching this area, you will not feel anything. The other problem in the definition here that the patient is so understanding of life. When you come to this area, he will give you a good explanation for you. If you don't have a family history or a history from a relevant story, you will not understand the case. And the story is coming very, very organized. For that reason, you should take a history from a relative. If you don't have that, you can't diagnose delusional disorder. What are the types of delusional disorder? There are many types really. And my experience that the undifferentiated type, one of the major types, we have the grandiose type, the persecutory one, the delusion of love. All of these are different types, but the undifferentiated and unspecified types are so many. A lot of cases come to my clinic unspecified. And one of the best treatment for this type of disorder are drug treatment. Cognitive psychotherapy, in my experience, will not work a lot of them. No. Then going to the drug treatment is very important.
The prevalence of delusional disorder is estimated to be 0.03% of the general population. And as we said, as the definition explains, there should be non-bizarre type of delusion.
Delusional disorder, it is a vague and very rare disorder. Really, it is very rare, but it's very interesting. And when diagnosed in our clinics, it is very interesting. Delusional disorder by its types, like persecutory delusion or somatic delusional jealousy, erotomanic delusions, grandiose delusion, as we said, is not common and very rare, but may be due to or may be caused by a definite personality character, characterized by persecution, jealousy, suspiciousness, and about 25% of cases become schizophrenic, and 10% continue to be mood disorder, depression, mainly.
If we speak about the terminology of delusional disorder, the definition of a delusion has already been talked about. However, there are certain terminology in terms of the different types of delusional disorders. There are several types recognized within the mental health professionals. One of the most common types of delusional disorder is the paranoid or the persecutory type. And in this type, the individual or the patient with the delusional disorder might believe that he is being persecuted, being chased, or being harmed by a certain group of people, or even one person. Another type of delusional disorder is the erotomanic type, in which the patient with the disorder believes that someone who has a higher social position than him is actually in love with him. An example of that, for example, an actor or a famous character or an individual, for example, even famous players, or let's, for example, take a female who has a erotomanic delusion. She might believe, for example, that the famous player Messi might be in love with her. So, and she really believes that, and believes that he's actually sending her flowers, sending her letters, and that's sometimes troublesome for the individual and for the family. Other types of delusional disorder, in terms of terminology, we have the jealousy type, in which the husband or wife might have extreme jealousy and suspicious of her spouse, and start watching him and believes that he's cheating on her, and so on. Another type is the somatic delusional disorder, in which the individual believes that certain organs in his body has ceased to exist or ceased to function. Or sometimes they believe that they have a strong belief that they have a major illness, for example, like cancer or a big problem, and it's a very strong belief that the patient cannot be convinced otherwise.
Many types have been specified for delusional disorder. The first one is the erotomania, or the erotomanic type of delusional disorder. The second one is the grandiose type of delusional disorder, the jealous type of delusional disorder, the persecutory type of delusional disorder. We have also the somatic type, the mixed type, and the unspecified type of delusional disorder.
To know the main types of delusional disorders, as there is different types and several types of delusion. There is somatic delusion, that the patient have negative false beliefs concerning one or more of his biological or organic functions that is completely impairment or deteriorated. And this is related to hypochondriasis, that the patient cannot understand or cannot perceive that he is normal and completely in a health state, but he think in different way that he is completely suffering from impairment in some of his biological functions. This is much more important. Another important thing to assess the severity of delusional disorders, to know other types of delusional disorders, such as reference delusion or delusion of reference. Perhaps you found the patient have negative false beliefs that people around him talking about him, looking at him, started to refer or following his steps at the street, so that this is a very pattern of delusion and may negatively affecting on his relationship with people around him. Another delusion you have to assess, the delusion of persecution. That people around him, perhaps family members or caregivers or his wife, may try to harm him or try to killing him. Another thing very important when you assess delusional disorders to identify whether this delusion at the beginning or it is chronic, started at early age in his adolescent phase or early adulthood phase between 25 years old or maybe less.
Carry the same cause for the same etiology of schizophrenic spectrum disorder. Maybe hereditary, maybe biological due to dopamine, noradrenaline, serotonin, or other hormonal dysfunction. Maybe metabolic or immunological immunocompatibility and uncompatibility or other biological causes. Maybe psychological factors, social stressors, and other psychological factors may be the main cause for these disorders, like paranoid pseudo-community characterized by characterized in some populations which carry weak diminished hearing or diminished visual acuity, or when travel abroad, some personnel under specific stressors or unspecific stressors became suspicious and paranoid, carrying the diagnosis of paranoid of the delusional disorder.
The treatment of delusional disorder, the biological treatment of delusional disorder includes the antipsychotics, and the psychological interventions are considered also to be a very important factor in the management of clients of delusional disorder. Usually we rely on doses of antipsychotics, and sometimes if we have a certain type of clinical pictures, we may add certain types of mood stabilizers, or sometimes we may add the antidepressants. I mean, the management of delusional disorder depends actually on the antipsychotics first, then we can add another type of psychotropics if needed.
For example, if we spoke about the paranoid type of delusional disorder, the patient have a thought that he's being persecuted, being watched or being observed, or even under surveillance by a group of people who wish him harm. And if you try to convince the patient that this is not true, he will not believe you, and he might take take steps and act on these delusions. For example, he might try to protect himself. He might believe that someone is behind him, so he might attack this person. So not only do they believe that, they might actually act on it. As I mentioned, to differentiate it from other psychotic disorders, there is no hallucinations, no other negative symptoms, and actually the functional impairment of the individual here is not as severely affected as it is in, for example, schizophrenia. So the patient might go on with his regular work or his schooling or academic without a strong or a significant impact on that area, which we call equivocal functional impairment. So the functional impairment is not really that clear, and so psychiatrists might fail to recognize that area and might think the patient is fine because he has no functional impairment. So I think that a psychiatrist should pay attention to that. And that's how we usually diagnose delusional disorder.
Male to female ratio are equal, but females are more prone to develop the erotomanic subtype of delusional disorder. Males are more prone to develop the jealous subtype of delusional disorder.
As with many other psychotic disorders, the exact cause of delusional disorder is not yet known. Researchers are, however, looking at the role of various genetic and biological factors. Genetic. The fact that delusional disorder is more common in people who have family members with delusional disorder or schizophrenia suggests there might be a genetic factor involved. It's believed that, as with other mental disorders, a tendency to develop delusional disorder might be passed on from parents to their children. Biological. Researchers are studying how abnormalities of certain areas of the brain might be involved in the development of delusional disorders. Faulty processing of information transmitted along brain circuits that involve perception and thinking are thought to play a role in psychosis. Antipsychotic medicines are believed to alter the flow of chemicals such as dopamine that are important for correct information processing along these brain circuits.
What is the main other diagnosis scan supporting delusional disorders? Psychotic features. Completely patient who suffering from delusional disorder may also induce some sort of schizophrenia, especially schizoaffective, especially and very important paranoid schizophrenia, that the patients have many suspicions and many doubts around people around him.
There is a potential medical etiologist for delusional disorder or for delusional syndrome. It may include the neurodegenerative disorder, the central nervous system disorders. It also could include the metabolic disorders, the infectious diseases, and many other disorders which could be an important etiological factor for the development of delusional disorder.
Well, if we spoke about the diagnostic feature of a delusional disorder, we find several differences between delusional disorder and schizophrenia, because sometimes this might create a challenge to psychiatrists in diagnosing and differentiating between the two disorders. In delusional disorder, we find that the individual mainly have a thought disturbance in the absence of any other features or symptoms of schizophrenia. This thought disturbance is usually a false belief. It is a fixed false belief that the individual is strongly holds on to, despite having evidence of the contrary to what the patient believes in. Well, in the case of delusional disorder, the diagnostic features might have similarities to other psychotic disorders, specifically schizophrenia. And this might be a challenge for a psychiatrist to differentiate between the two. But if we spoke about the delusional disorder and try to differentiate it from the schizophrenia, we'll find that the individual with delusional disorder has predominantly a thought problem, with the absence of any other symptoms or signs of psychosis like hallucinations or negative symptoms. And if we wanted to talk, if we wanted to speak about the delusional disorder and what it is actually a false and a fixed belief that the individual strongly holds on to despite the evidence of the contrary. So if you try to challenge the patient with his thought that it is not true or it's false, the patient will in no way believe that and will strongly hold onto his thought.
Advanced age, social isolation, family history of head injury are considered to be important risk factors for the development of delusional disorder. There is a certain risk factors actually associated with delusional disorder. For example, the sensory impairment, the old age, the family history, the social isolation, the presence of certain personality features which may actually contribute or be considered to be risk factors for the development of delusional disorder.
Symptoms: non-bizarre delusions, delusional thoughts reflecting situations that occur in real life with duration of 1 month or longer. Other symptoms of schizophrenia have never been met, except tactile and olfactory delusions may be present if consistent with delusional themes. Functioning and behavior are not markedly impaired nor odd or bizarre, aside from delusions. Duration of any mood symptoms accompanying delusional symptoms has been brief in comparison to duration of delusions. Disorder is not caused directly by use of substances or medical condition. Onset can vary from adolescence to late adulthood but tends to appear later in life.
Delusional disorder is defined as a certain circumscribed part of non-bizarre delusion, circumscribed non-bizarre delusion in the absence of prominent hallucinations and in the absence of significant impairment in mood or affect, and symptoms should almost always be present for at least 1 month.
Talking about signs and symptoms of delusional disorder based on the type of the delusional disorder. If a grandiose type would come with the euphoric feeling, euphoric mood, and the ideas will be coming like that. We're talking about delusion of love that's merely in the ladies feeling in love with one of the famous guys, and she's sending letters to him, he's sending back to her, he's not sending, but she feels that he's sending but missed in the post. Then the signs and symptoms depend on the type. Determining the type exactly, you will find the sign and symptoms going with that. No specific sign and symptoms of delusional disorder. It could be generalized in all types of delusional disorder. Then please, we should specify the type of the disorder for the subfamilies or friends or colleagues. If you find any abnormality, if you're a friend, don't look at it as just a strange issue and that's finished. No, you should specify this guy is deteriorating in his functioning or not. If there is a major deterioration in the function, you should specify, is it schizophrenia or just a specific delusional disorder which the patient is suffering from? Then according to that, we'll go to the management.
Delusional disorder actually is described when clients have non-bizarre delusions that usually present for 1 month in duration, and such kind of delusion cannot be attributed to any other psychiatric disorder. So there should be non-bizarre type of delusions, and delusions are false fixed beliefs that cannot be changed to the evidence of contrary, cannot be changed, cannot be understood if clients' background, cultural, social, and educational background are known. There is certain diagnostic criteria for delusional disorder. There should be non-bizarre delusion, which should present for 1 month. The criteria or the criterion A, specifically for schizophrenia, should never be present when we put the diagnosis of delusional disorder. Apart from the impact of delusion, a client's life are generally not impaired. So sometimes we need somebody who is professional, and we need to rely actually on the family notes actually to identify the nature of delusional disorder. I mean the impact of such non-bizarre delusions on the client's social, marital, interpersonal life should be considered when we put the diagnosis of delusional disorder. Of course, the delusion should not be, or the disorder should not be due to the direct physiological effect of substances, and should not be due to any other general medical condition. For the course, actually the course of delusional disorder is said to be actually sudden. So the onset of symptomatology or the onset of impact of symptoms on the client's life is said to be sudden rather than insidious.
Differential diagnosis of delusional disorder varies from a number of mental disorder can be differentiated by clinician this disorder from each other. Delusional disorder can be differentiated from other psychotic disorder, means schizophrenia and schizophrenic form, and brief psychotic reaction, and depression. Depression is the most common feature in this disorder, dysphoric or depressed mood or loss of interest. Differentiation from this delusional disorder is substance or medication-induced psychotic disorder. The history or laboratory finding suggests in this substance or medication induce this delusional disorder.
Treatment of delusional disorder often involves both psychopharmacology and psychotherapy. Given the chronic nature of this condition, treatment strategies should be tailored to the individual needs of the patient and focus on maintaining social function and improving quality of life. Establishing a therapeutic alliance as well as acceptable symptomatic treatment goals and educating the patient's family are of paramount importance. Avoiding direct confrontation of the delusional symptoms enhances the possibility of treatment compliance and response. Hospitalization should be considered if a potential for harm or violence exists. Otherwise, outpatient treatment is preferred. In general, delusional disorders were reported to be fairly responsive to treatment. Use of multiple medications was common, most often including a combination of antipsychotic and antidepressant medication. In addition, patients commonly received more than one antipsychotic over the course of their illness. And medication treatments were also complemented by other interventions such as cognitive behavioral therapy. For most patients with delusional disorder, some form of supportive therapy is helpful. The goals of supportive therapy include facilitating treatment adherence and providing education about the illness and its treatment. Educational and social interventions can include social skills training and minimizing risk factors including sensory impairment, isolation, stress, and precipitants of violence. Providing realistic guidance and assistance in dealing with problems stemming from the delusional system may be very helpful. Cognitive therapeutic approaches may be useful for some patients. The therapist help the patient to identify maladaptive thoughts by means of interactive questioning and behavioral experiments, and them to replace them with alternative, more adaptive beliefs and attributions. Discussion of the unrealistic nature of delusional beliefs should be done gently and only after rapport with the patient has been established.
What about the cognitive behavior therapy for schizophrenia? As we said before, that the main treatment of schizophrenia is antipsychotic and the drug treatment, but on the other hand, there is several recent studies say that patients who suffering from schizophrenia and taking drug treatment and also taking the cognitive behavior therapy programs may also present a significant improvement sign at early therapeutic program.
Nothing except drug treatment for delusional disorder. What if psychotherapy, cognitive, psychoanalysis, behavioral, all modalities will fail in dealing with this type of disorders. The problem with drug treatment that the patient will not accept taking drugs because he don't believe that he is mentally ill. Even he's very successful in his work. A lot of journalists, even accounts, people working in accounting, a lot of people working in the politics even, a lot of people working in finance, etc., in different specialties. They could have this disorder and they may be sometimes productive more than the psychiatrist treating them. Then he will not accept to take these medications. Sometimes should be by force. By force giving a treatment is depending on the human rights in that country. Some of the countries are allowed to give medication against the will of the patient. Some of the countries no. Some of the countries no, they are not accepting, but they are not following or not blaming really. For that issue, some of the families will get benefit of lacking of the human rights of those countries. Then, as you can help the patient to please in different ways is very important. The patient will blame you when you try to help him during his mental disorder, but when he become normal, he will thank you a lot because he will be incited about himself after using the proper medication and treatment.